I'm a gastroenterologist, which means that I'm a stomach doctor. So I see patients in the clinic. My other role is I'm a research scientist at the VA Center for Clinical Management Research. There I'm a health services researcher with a particular interest in ways to target preventive care to patients based on their individual risk and benefit. Very early on in my career, I realized that there was sort of a gap between what we knew was helpful and useful and effective for patient care, and what was actually being done in the clinical setting. And so I became very interested in how we could improve the delivery of the best science and evidence to patients. Some of the key challenges that my work addresses in the healthcare system includes challenges in identifying patients who are at particularly high or low risk for a given condition, figuring out how to target care to the right patient at the right time, and then also trying to develop novel and more clinically sensitive ways to measure quality of care and encourage delivery of evidence-based care. The impact of my work is largely seen in the clinic setting, where what we are able to do is to take a lot of the background work that we've done on predictive modeling, predictive analytics, and then try to implement that into what's happening at the patient and physician and patient-provider sort of interaction level. For example, in colon cancer screening, we know that while colon cancer screening is effective on sort of a population level, not every patient is equally likely to benefit from screening. And so what we've been able to do is to take information from predictive models about sort of who is likely to benefit and who is less likely to benefit, and then actually present that information to patients in the clinic setting to help them make more informed decisions about screening. I think the most important issue facing healthcare today is the same issue that I saw when I first entered medicine more than a decade ago, and that is delivering the best evidence and science to patients so that they can actually benefit from what we know as a field. Science continues to sort of rapidly evolve, and getting those rapidly evolving changes to patients at the point of care is, I think, one of the key challenges. The things that University of Michigan has that I think makes it unique and makes IHPI possible is largely its culture as an institution. I've been at the university now for more than 10 years. From the outset, one of the things that I noticed was how people were really interested in collaboration. That was really the culture of the institution. And also sort of protecting and promoting young people who are coming through who may have an interest in research and trying to really help them find their way. And IHPI was a unique opportunity to bring all those people to one place under a single roof, where that proximity and that sort of common interest could sort of be leveraged to the highest extent. There's lots of groups across the world developing ways to predict who's going to get a particular condition at a particular time, but sort of taking that information and actually getting it to patients in a way that works is a monumental task. And IHPI, I think, is really uniquely positioned to be able to affect that type of change, and then also to think about how to change policy as well on a more global level to really make and sort of encourage care that's of that type of quality and precision. One of the big challenges that I see is taking the vast amounts of science, information, and data that we have and really translating that into something that can be done in the clinic setting. I see that as a great opportunity for medicine, but I also see it as a challenge that not everyone's able to think about, because not everyone at other institutions, for instance, has the sort of the multidisciplinary tools and approaches that we have available to us here at IHPI to be able to address questions like that.